Hello students, welcome to the Paediatrics Pointer, your ultimate revision series, and today's topic is the childhood tumors. We'll be discussing in this section abdominal tumor, mainly neuroblastoma and Wilms tumor. Neuroblastoma overall is the most common malignant tumor in infancy. It is the most common malignant tumor in infancy, also with spontaneous regression. It is the most common abdominal tumor in children. Most common tumor in children with bony metastasis. Most common tumor in children with bony metastasis. It is the most common extracranial solid tumor in children. In children, overall, the most common tumor, acute lymphoblastic leukemia. Second most common is brain tumor. We are asking here solid, that excludes acute lymphoblastic leukemia, extracranial, that excludes the brain tumor. So this is regarding the most common of neuroblastoma. In the neuroblastoma, the most common site of origin in the body is the adrenal glands. There are certain syndromes which are associated, or the clinical features which are associated with neuroblastoma. One is the Pepper syndrome. Pepper syndrome is basically due to the metastasis to the liver, which may or may not be associated with the respiratory distress. Involvement of liver due to metastasis with or without respiratory distress. Then is Hutchinson syndrome. We have already told you it is the most common tumor with bony metastasis due to bone and bone marrow metastasis, which causes limping in the child. Werner-Morrison syndrome. This Werner-Morrison syndrome is the increased vasoactive intestinal peptide, which basically causes secretory diarrhea. Opsoclonus myoclonus ataxia syndrome. This is due to basically a paraneoplastic syndrome. This is due to the antibody production. Opsoclonus is there. There is basically movement of the eyeballs. Due to ataxia, child is not able to maintain the equilibrium. That's why clinically it is also called as dancing leg, dancing eye syndrome. Then this can also present with Horner syndrome if it is arising from the sympathetic chain. What are the sites of metastasis? In the Pepper syndrome, you already know it is liver metastasis, Hutchinson syndrome, bone marrow metastasis and bone metastasis. Apart from this, lymph nodes are the site. Lymph nodes, long bones of the skull plus bone marrow and liver. How to make a diagnosis? When you suspect, so this can arise particularly from the adrenal glands or from the sympathetic chain. So we require to go for CT, MRI, both of the chest or the abdomen, plus bone marrow aspiration. And in the bone marrow aspiration, what you can get is the small round blue tumor cells plus bone scans to detect the bony metastasis. There are two tumor markers which are present in the urine. Both are the metabolites of the particularly hormones produced from adrenal medulla, homovenalic acid and vinyl mandelic acid. What is being said? If in the urine VMA and HVA are increased, and in the bone marrow there is presence of small round blue tumor cells, that makes the diagnosis of the neuroblastoma. Prognosis, we say favorable, unfavorable. Favorable is less than 18 months, unfavorable more than 18 months. Just remember the earlier line, most common malignant tumor in infancy associated with spontaneous regression, neuroblastoma. So lesser is the age, more good is the prognosis. Hyperploidy favorable, near diploid unfavorable. CMYC not amplified is favorable, amplification is unfavorable. Tyrosine kinase A present favorable, absent unfavorable. Tyrosine kinase B absent is favorable and present is unfavorable. These are the prognostic factors. Can we give any drug? Yes, now we have got a drug, dinutuximab, which binds to the GD2 receptors which are present on the neuroblastoma cells. Moving on to the next one, we talk is the Wilms tumor, also called nephroblastoma. It is the second most common abdominal tumor of children. Most common abdominal tumor is neuroblastoma. This is the second most common, and it is the most common primary malignant renal tumor of the children. This is associated with certain syndromes, which can be one Vagar syndrome, Danish-Drash syndrome, Beckwith-Wiedemann syndrome. In Vagar and Danish-Drash, there is involvement of WT1 gene, and in Beckwith-Wiedemann, involvement of WT2 gene. Vagar, W for Wilms tumor, A for aniridia, G for genitourinary abnormalities, R for retardation, mental retardation. Danish Drash, there is renal mesangial sclerosis along with male pseudohermaphroditism. Beckwith Wiedemann, as such the body size increases, asymmetrical or hemihypertrophy is there, organomegaly, macroglossia and omphalocele is there. So overall the body size increases. Clinical features, what is the most common presentation? That is the asymptomatic abdominal mass. Can also present with hypertension, can present with hematuria, right? Hypertension, more amount of renin secretion by the kidney. Hypertension can present with abdominal pain, more amount of erythropoietin can cause polycythemia. But overall, if we consider which is the most common presentation, the most common presentation is the abdominal mass is there, asymptomatic abdominal mass. Metastasis goes to three places: lymph nodes, lungs and the liver. Mother notices a asymptomatic abdominal mass. What is the first investigation to be done? Ultrasonography. You want to know this is a solid or a cystic mass. You can also go for abdominal CT plus MRI, and you go for the histology, that is particularly triphasic pattern in the histology, and the basically biopsy is done after nephrectomy. The point here is biopsy is done after nephrectomy, and basically triphasic pattern, you can remember the word best: B for blastema, E for epithelium, S for stroma. This is the triphasic pattern you can get in the histology, but remember histology is done after nephrectomy. Here the prognosis does not depend upon staging, prognosis depends upon histology. So histology will basically tell you regarding the grading, so the prognosis depends upon the grading. What is the primary treatment? Nephrectomy followed by chemotherapy with vincristine plus actinomycin D. After this, the radiation therapy to be started, and this radiation therapy to be started within 10 to 14 days of the tumor resection. Again a repeated question, that is within 2 weeks of the resection of the tumor. Thanks for watching. Do follow the channel for the further pediatrics revision series. All the best. Happy learning.